Now, in the name of Almighty, most merciful and beneficent, I have given you in part 4 the 5 plain XHS, and it should be interpreted. Well, I think the answers which can be given by me, although I'm not a very expert person of this field. As a clinician, yes, I am. I'm Professor Sayyid Ali Haider. But argument can be there, of course. The simple answers will be presented to you. So the first X-ray which is given by me is this one. That is, I think you picked up, a 60-year-old who was admitted 1 month back in ICU for some respiratory issue, presented with a fever, with the rigors, and associated with the perineal expectoration since 7 days. History is 7 days now. Past history is significant. Medical officer, who is also the family physician, noted recently developed digital clubbing. So this is the X-ray which was given, the XHS view, as well as the lateral view, right lateral view was given. Now by interpreting these X-rays, that very clear things, afterwards you see the trachea was central, associated with the pathology in the lungs. The pathology lies in the right side, in the right middle zone. It is about 6 by 4 centimeter oval lesion. All the boundaries are visible here. You can see. And this is a homogeneous opacity with a fluid level inside it. There is fluid level inside it, confirmed on the right lateral chest view. Now, if you look the border of this opacity, it is just like this, going up and down, and here the border is this. Roll down, there is slight, you can see the congestive changes are seen, non-homogeneous type, here, this part. The upper part is hypertransparent because of the compensatory emphysema. The lesion described is a cavitating lesion. It's a big lesion involving whole right middle zone. And this was the description given by me. Now, the first differential diagnosis which can be made here, because he was admitted in the ICU for some respiratory issue, and now he is presented with fever with rigors, with pleural expectoration, and recent digital clubbing. This is most probably the result of the acute inflammation of the lung, that is pneumonia, and the one thing which is the common one is the pulmonary abscess, lung abscess. This is the result of the acute inflammation of the lung. The evidence why I am saying this, because the lower part is involved. Look, this is a non-homogeneous type of the radio opacity. There is a ear bronchogram which is visible. It is the gray polarization which is seen here, according to my experience. The first diagnosis is a acute inflammation resulting in the pulmonary abscess. The second one, it may be the possibility of the chronic inflammation, or the result of the chronic inflammation, means tuberculosis with cavitation is possible. The third one means the possibility of another chronic inflammation which can cause this is the fungal infections. The fungi which can cause any type of the lesion. There are many presentations of the invasive fungi. It may be possibility because of this as a result. The third differential or fourth differential will possibly least chances, but there is a possibility of what is we call is a cavitating bronchogenic carcinoma. Can present with like this in 4% of cases. Of all bronchogenic tumors, malignant, 4% may present with this. The other possibilities other than this is the possibility of some other differential may be made in addition to it. I want to add the autoimmune disease, like for example the Wegener granulomatosis, which is causing the cystic type of lesions. They are multiple usually, but not all. And wandering type of the cavitating lesions. This is the very, very important point in the Wegener's granulomatosis. Microangiopathy with polyangiitis that is Wegener's granulomatosis possibility. Another possible differential, sir, is it is either the amoebic type of abscess, it is a secondary to the hematogenous spread of the amoebiasis in this part of the world is a common one. The lesion is very big. So another possibility, another parasitic infection, that is Echinococcus granulosus, that is Hather's cyst. But because there is no evidence of the exo or endocyst, and there is hardly any calcification or qualification in it, there are least chances. So the most common one is the inflammatory condition, that is the pulmonary abscess. The other investigation you can do is SRCT, the sputum for AFB. You can go through the CBC to confirm it, leukocytosis, neutrophil leukocytosis, and you can go for the other systemic parameters for it, like for example liver function test because of the septicemia it can cause, and you can also go for the renal function tests for the sake of the management purposes. You have to give the drugs. And you can go for the urinary examination of the pneumococcal antigen, which is possibly the direct evidence of the etiology of the abscess. Abscess is concerned. Urine DR the sputum DR should associate it with AFB. If the lesion is not diagnosed, after all the efforts, the bronchoscopy can be done, and the CT guided biopsy in the lower part can also be done. The management is the acute inflammation, if it is found. So the parental broad spectrum and the fourth generation cephalosporins or meropenems or carbapenems or aztreonams, etc. These are the drugs which can use parentally. Nowadays, the American College of Physicians recommends the third generation macrolides azithromycin also. The second was a 36-year-old developed fever, cough and restlessness for the last 10 days. After interpreting all the axes here, this is the trachea which is going on, the other things which I have told you previously. Here the congestive changes are seen here. The bronchovascular marking touching on the lateral wall. Reactive type of the condition, I will say. And here you see there is the costopharyngeal angle is gone and the cardiopharyngeal angle is gone, and there is a homogeneous opacity acquiring the lower zone and part of the middle zone. And there is a curve which is very, very significant, like this. This is what we call as the lunar semilunar sign, or we can also call the Ellis curve. it means that the pleural effusion occurs. And there is also what is the heart lower borders is engulfed in this opacity. This is Silhouette sign. Means that inflammation occurring in the parenchyma and the pleura. Look the above of this seminal curve you find here. This is this part, very small part. This is the evidence how it occurs. This is a non-homogeneous type of haziness, air broncho and pattern. So it is a resolving type of the acute inflammation, probably pneumonia, which is causing it. It is a parapneumonic pleural effusion most probably. But this type of the pleural effusion can occur in the other condition as well, that is chronic inflammation, that is in tuberculosis. It can also occur in the other condition as well, like the congestive cardiac failure, and you have given the furosemide in heavy doses, so the resolution of the pulmonary edema and is a remnant of it. There's possibility of this. Other systemic condition which cause the pleural effusion, possibility of the hypothyroidism. But this big effusion, usually it is bilateral, most of the cases. It is a blood-sided one. The fungal infection can cause pleural effusions. It may possibility the malignancy hidden inside. The paramalignant pleural effusion is possible, also differential. These are the most important differential diagnosis which can be made by this. The other investigation we do is the left lateral view or HRCT, sputum for the DR, and sputum for AFB, culture and sensitivity. Then we further investigate, and the best investigation you do is the diagnostic fluorosynthesis. You also calculate the serum albumin levels, and you can make that your diagnosis, confirming that it is exudate or transudate, although you know that about it. That is, the high protein levels more than 2.5 gram, LDH levels is 2/3 of the above normal, etc. It consists of the very low glucose and high, purulent type of a pleural effusion is empyema thoracis. By the analysis of the pleural fluid, and it's compared with this one, with the albumin, you can appreciate that it may be transudate or exudate. Just like SAAG, that is serum albumin, serum is acidic albumin gradient. In this case, the serum pleural albumin gradient. This is spark. That is a SARC, this is spark. You can differentiate between transudate and exudate. Other investigation should be done. If you are going for the pleural tap, you can remove as much as you can, so that the level should be decreased, so that the heart is visible, and the compromisation, because he is breathlessness, in breathlessness, it will benefit this patient. And the healing occurs very quickly afterwards, if you remove it as much as you can. Broad spectrum antibiotics now should be used, and other symptomatic measures should be done. There's a long list of it. I don't want to discuss because of the lack of time. The third one, a 56-year-old smoker presented with a low-grade fever, pleural expectoration, loss of weight, breathlessness on exertion. A long history is given 4 months. So it is 4 months, a prolonged fever, and for us it is PUO, or FUO. He had taken 3 courses of broad spectrum antibiotics during his illness. So this is what is seen here. Look, the thick bands of fibrosis here, entrapped air inside, hypertonsillencies, on that side also the non-homogeneous radiopacity with slightly some fluid levels are also seen. One is this, one is this, and the costophrenic angle and the cardiophrenic angle is not visualized properly, and this is the part where the homogeneous opacity is there. Although costophrenic angle is here, it is the costodiaphragmatic recess which contains the air. So it is definitely, if it is there, it means that the pleural effusion is not there. It is entrapped pleural effusion, it's a possibility, but the chances is there. This is a reaction of the pleura. Pleural fibrosis occurs. Thick bands, pleural fibrosis, cross over the band causing the cavitations, multiple cavitations, different in parts. So this is the condition. On the other side, a flat dome of the diaphragm because of the compensatory emphysema on that side. So this is probably the chronic inflammation of the lung. Acute inflammation chances are less. The chronic inflammation chances are more. And that is tuberculosis in this part of the world is very important. The other chronic inflammation which can cause this type of the fibrotic bands and the cavitations, the fungal infections can cause invasive type of fungal infections. Risk can be made. It may be cryptococci, it may be coccidiomycosis. These all can cause this. Not specific lesions are seen with the fungi. What about the malignant condition? No malignant conditions can cause this, because this is a cavitations multiple, not one. Maybe it is secondaries in the lungs which causes these type of the cavitations. Possibility with the pleural reaction is possible, but least chances. The other condition can cause this sarcoidosis, can cause the lesions. The other condition which cause the fibrotic reaction along with the cavitations, vaginal gametosis. But vaginal gametosis will cause the wandering type of the cavitations. 3 days before the here, now here, afterwards, the wandering. Most probably it is a chronic inflammation of the lung, and that is the tuberculosis causing the multiple cavitations. So we will go for the HRCT, we go for the other tests like the sputum for AFB, DR with the AFB with the culture and sensitivity, and gene expert to confirm, which is a very, very sensitive test nowadays. Ultrasonography of the lower parts, it is pleural effusion. If it is found, then you take it out and go for the analysis, and it will enhance your diagnosis. So the other investigation you can do are the systemic type of investigations along with it, CBC, ESR, and the acute phase reactant like CRP, etc. If the all cannot be diagnosed, then we go directly biopsy the lesion through CT guided or ultrasound guided biopsy and see what is there to confirm 100% direct evidence. The treatment, if it is positive, then you have to start the anti-tuberculosis therapy. We here in Pakistan we are giving the 4 drugs for the 2 months and the 3 drugs for the 4 months. 2 plus 4, 6 month therapy. A 36-year-old farmer presented with refractory asthma. Refractory asthma means that all has been done. All therapeutic measures you have taken, but still there is asthmatic condition persists. Farmer. Farmer means there may be a farmer lung? No. Farmer lung means extrinsic allergic rhinitis. The evidence is not there for extrinsic allergic rhinitis. It is something going more than that. And this is the lesion which is described here. Now this is again a rounded shaped lesion. It has got the wall. The first one is this. Second layer is there. There is air inside. And third point is the inside it there is a globular type of opacity which is hanging. It is a whorl appearance. One layer, two layer, three layer like this. So this is the what is called as the ear crescent sign in the cavitating lesion, or air and air sign. First layer air, and then the second layer air, and then this ball which is called a fungus ball inside it. The first diagnosis is radiological sign of this is the aspergilloma. You have to confirm it by the blood CBC and the differential and the absolute eosinophil count, which should be more than 1500. If it is, then most probability it is aspergilloma. Aspergilloma occurs in three varieties. One is localized as aspergilloma. It occurs in the cases of the empty cavities, like tuberculosis cavity, which was previously infected with the tuberculosis. Now there is an empty cavity, and this is the ideal place of their growth. And the other things, other types or other variants are invasive type of the aspergillosis, and third one is what is called as pulmonary eosinophilia. It falls in the pulmonary eosinophilia, and the other differential may be possibility of the tuberculosis, chronic inflammation with the tuberculosis. Yes, it may be abscess, these chances, because this is not, clinically it is not like this. And the other differential may be possibly the hydrocephalus, the exocyst should be there, the endocyst should be there very clearly with the fluid levels, no fluid levels here. And the hydrocephalus not got the calcification if it is so much old, or cornification. HRCT, lateral views of the chest, and HRCT should be done in this patient. The sputum for AFB, you will find the eosinophils and the other things of the allergic type of reaction in the body, charcoal-laden crystals, Kutschmann spirals, etc. Possibly in the microscopy of the sputum it is possible. You go for the AFB also in this condition. To exclude it, you have to do it. The other systemic investigation should be done, and then intradermal test for the aspergillus should be done also for the more confirmation. The thing is this is a fungal ball inside, so no drug can penetrate in this lesion, very difficult. Again, the systemic steroids have gone according to the new recommendation that it should be given to suppress the eosinophils, because this is a mass and it's caused by the large amount of the eosinophils. Suppress the eosinophils by parenteral and by the oral steroids and taper it off. So the asthma will be controlled like that. Asthmatic because of bronchospasm, it causes bronchospasm and bronchospasm and bronchospasm. So this is the management part of it. The heroin addict experienced the fever with the arthralgia since 3 months, presented in OPD with a chest pain and severe breathlessness. Examination revealed the grade 4 pansystolic murmur in the tricuspid area. This is an important one. Look closely this skyground, you see, take a central, nothing, see the bronchovascular markings are there or not. The definition of the bronchovascular markings is not present here, because they should arise from the hila, they should distribute a 90-degree angle, and they taper at this end. Now here there is a crossover bridges here, there. Very close examination of the magnifying glass will see there are the arrowgrams in the cavities, in a cavitating fashion. Here and here and here and here. Small, they are small, some are big cavitations. Now in this case, according to the scenario and the pansystolic murmur is heard here, a hydronetic possibility of the bacterial endocarditis of the right side. It is infected, and if it is broken down, it will carry out to the pulmonary artery to the lungs, and it will cause the septic type of the pneumonia in this condition because of the infected emboli. Where the emboli lies, there will be reaction and there is a small cavitations. So it is a suppurative type of the pneumonia which is seen here, and it is most probably because of the bacterial endocarditis. So go for the investigations. For this you can do the HRCT to confirm more of these lesions which are seen here. They are small ones. And then go for the specific investigations for the bacterial endocarditis. The echocardiography should be done with tricuspid regurgitation, get 4 pansystolic murmur in the tricuspid area. Go for it and see any vegetations on it. You can also do the what is called the angiogram, CT angiogram of the lungs for the more confirmation of the embolism. And you go for the ELISA D-dimer to see the systemic embolization occur along with the pulmonary embolization or not. And you will apply it here the criteria for the diagnosis for the bacterial endocarditis. It will confirm this condition. The management is nothing you can do, but you have to give the broad spectrum antibiotics in most of the cases. In our country, we use triple regime because we are economically not very strong, covering the both gram-positive and gram-negative bacteria. So we give actually amoxicillin plus gentamicin plus metronidazole. And if the person can afford, then go for the other third, fourth generation cephalosporins, and you can also give the carbapenems or the azithromycins. You can give the macrolides, and if it is not responding, go for the other drugs like vancomycins in addition to it. You can go nowadays, it is recommended that the moxifloxacin can also be beneficial with combination of the vancomycin or other antibiotics. As a last resort, if it is not solved by this, you can give the linezolid along with the other antibiotics, triple regime with the linezolid. So this is how we manage these cases. I hope that very short time I have discussed these cases. I hope that you have gained your marks, compare your answers, and we will meet again. Goodbye, good morning, Allah Hafiz.